Hey, welcome to Perio Part 3 at rdhblueprint.ca. My name is David. Who's excited about almost being done? This guy. And I bet you are too. This is a short chapter. You'll be happy about that. Let's talk about sutures, maintenance, and implants. Okay, she's got some sutures. This is a bit the inside of her mouth. You can see the sutures. Just a fancy word for stitches. Sutures, they hold tissue together for optimal healing and clot formation. Makes sense, right? There's the absorbable, like gut, okay, like cat gut sutures. And then there's the non-removable ones, right? And non-absorbable, like silk. So they have to be removed. Silk needs to be removed. It will not just disappear by itself. But cat gut will be absorbed and you don't have to remove them. We all prefer the non-removable ones, right? You just put them in and leave it. That'd be nice. So what do we have to do to remove sutures? Remember, this is something within our scope of practice as a hygienist. So first, you explain the procedure. You're going to talk to them, right? You're going to tell them what's about to happen, the rationale, and get their consent. You're going to cut the sutures, and you're going to pull the knot over the laceration, over the cut. Don't pull that knot through the holes, right? You don't want to do that. You don't want to pull the knot through. It's going to bust through. And you don't want to pull away because that may open up the wound again. So you're going to grab the knot with your little pliers, cut underneath, and then pull the knot over top of the laceration where it was. You're going to count and record the sutures. You're going to clean the area and monitor for bleeding, give post-op instructions. So let's go over this again. Here's the things. We cut the part exposed to the mouth, gently pull the knot, not through the tissue. That couldn't be more wrong. Around the tissue. Over the tissue is actually a better way of putting it. And that's how I'm going to update the slides. Over the tissue, count and compare to the placement cord, and clean the area and monitor for bleeding. That's it. Dressings or periodontal packs. They offer protection and comfort, but they're not essential for healing. Removed within 5 to 7 days. Mostly non-eugenol zinc oxidized based. Clear, light, cured types. So how do we want to manage the discomfort? Ice. Don't have spicy foods. Don't have really cold, hard foods. We want soft, basically lukewarm things. Maybe it's slightly cool. Have it feel good. Have some smoothies. No smoking or alcohol, please. Don't rinse on the first day. That swishing force can pull sutures out. Gently rinse with lukewarm water or chlorhexidine on the next day. Clean dressing gently with a soft brush and report abnormal bleeding or swelling. So we want to see them within 7 days for dressing and suture observation or removal. Provide self-care instructions. So that can be a board exam question. How many days? 7 to 9 days of suture removal. Desensitizing agents may be recommended for exposed roots. And then you'll be in active therapy. We want to be looking after that area, right? Surgical and non-surgical. Lifelong maintenance is essential to keep things healthy. So we want to prevent reoccurrence, preserve the teeth and implants, reinforce effective oral hygiene, and detect worsening issues. Do a full assessment with the charting, probing, and radiographs. Treat plaque and calculus, scale that off the teeth, and schedule every 3 months for periodontitis patients. Shorter intervals may improve outcomes, and they can be longer if they're showing, great results. So if they're healthy, we do supergingival cleaning only. We don't need to go under the gums and clean aggressively. The bleeding, debride, and possibly antimicrobial agents. Pockets, we want to scale the roots and then come back in 4 to 6 weeks. If they have poor control signs of relapse, you may require surgery. What is an implant? You know this stuff, right? A biomedical device that's made of biocompatible materials, meaning it's compatible with living tissues like titanium, placed into the jawbone. So it's embedded in the bone. There's the abutment that connects the crown or the denture to the implant. The superstructure, this is the prosthetic part. This is what you can see. And the implant-assisted prosthesis, the removable denture. So here's a single-stage dental implant. It's just, they drill it in, and the crown has the abutment built into it. It all goes in. Or it's 2-stage. You have your implant, your abutment, then your crown. Contraindications and risk factors. We want to delay until the jaw growth is complete. We want the jaw to finish growing. You have risks of osteoporosis, immune disorders, malnutrition, other things like uncontrolled diabetes. All these things put you at risk for a failure. The implant's not going to take. Smoking also increases the risk of implant failure. So a two-stage submerged implant is placed to allow it to heal under the tissue, then it's uncovered. So the implant is put in, you stage over, then you come back later and you're going to reopen that wound and put the abutment and crown on. One stage, non-submerged, the implant collar is exposed at the time of placement. So the abutment is showing. It's not going to be hidden by the tissue. We're going to want titanium or hydroxyapatite coating. That can facilitate osseointegration. So your bones are made of hydroxyapatite. So when you have that on the titanium, it's sprayed on, the bone is going to integrate into the titanium really well. So types of implants and success criteria. We have endosseous, within the bone. Transosseous, so through the bone. This is when we get the best osseointegration, is endosseous implants. You can expect 1 to 2 millimeters of loss within the first year. So it shows 1 to 2 millimeters of loss in the first year. That's not a sign of implant failure. After that, it'll be basically, then it's going to be 1 to 2 millimeters every 5 years after that. So the first year, we get as much as we're going to see in the next 5. Transosseal is through the mandibular for overdentures. Implant tissue interface, the perimucosal seal, the biological seal. That's between the implant and your soft tissues. That stops bacteria from getting down to your bones. It's going to attach by hemidesmosomes because we have 2 different types of cells. There's no periodontal ligament. There is no PDL attaching to the implant. That's gone. But they are ankylosed. They're permanently attached to the bone. And what happens is this bone is actually going to grow between the grooves of the threading on the implant, which is nice. Success criteria, we want no mobility. If we see mobility, it's a major indicator of failure right there. No radiolucency or signs of infections, so we should see the bone looking nice, the same opacity as it was before. We don't want to see discomfort or bleeding or exudate stuff coming out of it, right? Nothing should be coming out, oozing out. And we have about 85% success at 8 years. So at 5 years, so 5 years after the implant, 85 has succeeded. At 10 years or more, 80% have succeeded. So we have a great success rate with implants. How do we monitor? We want to control the biofilm, inflammation, and probing. Very light pressure. It needs to be cleaned. Use titanium or plastic instruments. We need to debride the implants. We need to evaluate the bone loss. They should do a PA probably once a year, the doctor will recommend. And we need to educate them on looking after their implant. Soft bristles. Do not use those tuft-ended brushes, right, with any metal, because titanium is a very soft metal, so you'll take away that metal. We can have peri-implant health. Now, just as we had Periodontal Classification 2017, they classify implants completely separately. Very similar, but different. So we have peri-implant health, peri-implant mucositis. This is like basically the gingivitis of implants. Then peri-implantitis. Now we have bone loss. This is like the perio of implantitis. And then we have tissue deficiencies. We just have loss of bone for various reasons. Remember, we stage and grade implants separately from the rest of their mouth. If the board exam gives you a tricky question, like the probing depth on an implant was 4, the probing depth on the 1/6 natural tooth was 5, what stage and grade do they have? Well, you only have 1 tooth with probing depths. So we need it in 2 or more areas, non-adjacent areas to be perio. So we're not going to call it perio, right? Because the implant doesn't count. The implant's in its own category. Bony defects. We're almost done. We talked about this in our first lecture. We're finally getting to it. These refer to vertical bone loss in a certain pattern that occur in the alveolar bone. We classify this by how many bones are left. You can think of this as opening your window, opening your balcony. You go outside. When you walk outside of the tooth, how many walls do you see? I come out of my tooth, I'm looking, and I see, oh, I can see 3 walls. I can see the gums on 1, 2, 3 sides. That's a 3-wall bony defect. Or really, we're looking at bone. We can see the bone on 3 sides. That's a 3-wall bony defect. A 2-wall defect, I can now see the tooth across from it. I only have 2 bones appearing. That's a 2-wall defect. If I only see the bone on one side, we've completely lost the bone on one lateral side. There. That's a 1-wall defect. Now, what do you think is going to be harder to rebuild? If you want to rebuild that tissue, do some type of bone graft, put something in there. What's going to work well and what's not? Well, it's going to be easiest on a 3-wall bone defect, isn't it? Because you have containers. You have other walls that you can just pack the living material in, or the synthetic material, and it's going to have a place to go. With a 1-wall defect, there's nothing keeping it from spilling out. It's going to be harder. So 1 wall remaining and a 1-wall defect, that's the worst, often called a hemiseptum, poor regeneration potential. It's going to be very hard to regrow that. 2 is moderate regeneral, and this is the highest potential. So 3-wall defects are most favorable for a bone graft or regenerative therapy. 2 walls craters are more common in posterior teeth and treated with scaling, root planning, or surgery. And 1-wall defects often require resective surgery. That is the end of Perio. Good luck doing the questions I posted online. I wish you guys all the best. And remember to do your farm, do your medical emergencies, do your local anesthesia, do these hard questions over and over and over again. And know your staging and grading. If I can only recommend one thing from the whole Perio course, know that biofilm or bacteria is the etiological factor for periodontal disease. And please know how to stage and grade like that. Okay?